Hi, everyone. We are live at the new Cardiovascular Horizons Conference in New Orleans, Louisiana. So if you hear a lot of noise in the background, I am in the exhibit hall at the Global PAD Association booth, and we have a live broadcast of what's happening in the main hall with all of the speakers actually being simulcast in this exhibit hall as well. So it's very loud. I hope you can hear me okay. We have with us one of the most amazing speakers and one of my favorite doctors, Dr. Bret Weichmann. He is over in Gainesville, Florida, but he's right here. He was speaking at this event, but also here at this event, always learning new things, hearing about some new cutting edge technologies, techniques, and also Mary Yost. Before this call, you were speaking about Mary Yost and some new surprising statistics about PAD that you might want to share.
Yeah, well, thank you for having me on, Kim, first off, and glad to be here in New Orleans. Yes, Mary Yost is kind of the guru, if you will, of a lot of the epidemiology data that we rely on to help guide not just patient outcomes, but things like screening programs, who's going to benefit the most. And one of the things that she was mentioning was that the models that we use historically for estimating the prevalence of PAD, particularly in the United States, is flawed, and that the more accurate numbers being quoted from, at least historically, 8 to 12 million is probably closer to double that, really closer to that $20 million or $20 million people prevalence. And so when it comes to deciding who we're going to treat, we have to know who the potential patients are. And so if the numbers are off from the very beginning, and a lot of things, as you know, have been centered around, are we treating patients too soon in the disease spectrum? But if that number is twice of what it really has been quoted as being in the past, then clearly we're under treating, and it's all about disease recognition and awareness. And part of Mary's talk was essentially about that.
You bring up a really good point, because Alan came in with the question. He says, why won't doctors treat a blocked artery sooner when it's easier to potentially get through versus waiting until it becomes a lot bigger and more tough to treat and requiring potentially more trauma to the vessel and how you treat?
Here's the challenge with that. There are patients that can be completely asymptomatic even though a blood vessel may be blocked, because your body has its own way of developing what we call collateral circulation around a blockage from something like a large atherosclerotic burden. So we don't want to treat necessarily a blockage. We want to treat the patient. Now, having said that, some patients being asymptomatic, what we're finding, and to the point I made before with Mary, is that some of these patients may be asymptomatic, but you have to ask the right questions. So a patient may experience leg pain, and they'll say, well, I played football in high school, or it's my sciatica, or I've got rheumatoid arthritis. It's just that flaring up again. So unless you get very specific about the questions that you ask as a physician, getting to the root cause, is vascular disease a potential cause for these symptoms? A patient may be dismissed as being asymptomatic. But getting back around to the original question, we don't necessarily treat a blocked artery to open it up. We treat it with the goal of making a patient more functional in terms of their usual daily activities, their ability to walk pain-free, and so on. So the blocked artery itself isn't really the indicator. It's the blocked artery in the presence of appropriate symptoms that we can attribute to that blockage. Hopefully that answers the question.
Right, but then waiting until we get possibly some new evidence that shows what are the chances in so many of these patients that this short focal lesion is going to grow into this long calcified occlusion and become your Achilles heel in the SFA, for example, or in the thigh.
Really good point, and it kind of goes to that same original question, which is, in those scenarios where a patient, let's say even before they get to see a physician, they dismiss it on their own as neuropathy or an old injury. what happens in that scenario is that allows the disease progress, it allows the disease to progress to the extent where maybe some of our less invasive options are off the table. So patients, not only are they may not be a candidate for angioplasty or a less invasive approach, maybe the disease progresses to the point where they're starting to get color changes or wounds that won't heal or gangrene. But not only just from a treating the vascular lesion itself, but these patients then go on without any optimal medical therapy, which is just as important. These patients, if they dismiss the symptoms, maybe they've got blood pressure that's out of control, and we miss the opportunity to get that under control. Maybe they have diabetes and their blood sugar is out of control, and we miss that opportunity to optimize their medical therapy. So only 1/3 of patients with critical limb ischemia, despite our best efforts, end up getting optimal medical therapy. And we don't know what the cause is of that. Is that from patients not being compliant? Is it from physicians not recommending the appropriate therapy? But the point being, if we let things go and we don't identify the right patients, then they absolutely will or absolutely can progress to situations where our options from a procedural standpoint are limited.
Right. So much more needs to be done in studying who has the greater chance of having disease progress despite all of the best efforts, conservative therapy with walking and medicine and diabetes control, because 1 in 3 people over age 50, right, who have diabetes end up with PAD. And we have so many diabetics that even with their best effort to maintain their their A1C levels, their pad still progresses. And it's just a nightmare. If only the doctor would have treated them sooner. And yes, it may have been a revolving door, but maybe that blockage wouldn't be so tough, especially the ones below the knee, sooner rather than later. And so I think more needs to be done to identify these patients who are most at risk of, no matter how many efforts you make, they're still just going to progress. And those are the ones that we're going to need to keep a close eye on.
Yeah, I would agree with that. And I kind of liken that situation that you just described to patients that are identified with an early stage lung cancer, for example. The treatment options and the ultimate outcomes are better if you identify a patient early on in the progress. And I think that's what you're saying too.
Yep. I had a patient come to me and tell me that her vascular surgeon told her that she wasn't sick enough to see her or anyone on the team. And it was just incredibly disconcerting, because what's the next step for that patient? Well, they're not going to show up at any other doctor's doorstep until they have a wound that won't heal, and the only option at that point is amputation, and they show up in the emergency room, right?
That's right. That's right. Yeah, it's just allowing the disease to progress. It's like somebody coming to you with a stage 1 cancer and saying, "Oh, you're not sick enough. Let's wait till it gets to be stage 4, and then we'll try and throw a Hail Mary and see what happens."
Yep. Exactly. You never treat a cancer patient like the way in which PAD patients are treated. And so much more needs to be done. And it's very inspiring to have doctors like you and to see so many doctors at this particular conference that I'm even listening to, aside from you right now, who are really trying to advance the medicine for PAD and give us so much hope that, hey, you know what? We may not be able to find a cure, but we may be able to save everyone's legs at some point.
Yep, I agree with you 100%. And meetings like this do such a good job of raising all the important issues. One of the things that we were talking about earlier today was why are we failing at screening some of these patients? And Mary did a great job of identifying the patients that in 2024 with the incidences, as you mentioned, of PAD appearing in younger patients. Rising obesity epidemic, diabetes still on the rise. All those things are risk factors, we know, for PAD and its progression. So if we're not going to screen just based on age alone, for example, let's at least screen for the patients that do have some of these elevated risk factors. I think that's the key to, or one of the keys to identifying patients earlier in the disease process.
Definitely. Let's get to Douglas. Douglas, you have a question, and then next up we'll have Marcia. Douglas, what's your question for Dr. Weichmann?
Yes, sir. Thank you for joining us today. It's a pleasure meeting you. I was chatting with someone earlier, and they had asked me this question. How much do their HDLs, the high, low, and A1C and all that play a role in our PAD?
In general, we can identify four main risk factors for PAD. One is high cholesterol, one is high blood pressure, one is diabetes, one is smoking. So of the four, all of those they all play a role. HDL and appropriate ratios of cholesterol is certainly important. And as I was saying earlier, only about 1/3 of patients with critical limb ischemia end up with optimal medical management. Now, what does optimal medical management look like? Well, in general, for patients, as you were saying about HDL and LDL, those patients need to be, most of those patients need to be on statin therapy in order to optimize that as best you can. Not everybody can tolerate statin therapy, however, and so it becomes a balance of the right medicine at the right dose to get the numbers in the right range, if you will, to minimize risk, your overall risk from a cardiovascular standpoint, but specifically as it pertains to PAD. So we absolutely take in HDL and LDL, triglycerides, total cholesterol into consideration when we're trying to optimize the medical therapy. I will tell you that many of my patients that I see by the time they get to me are already on some form of lipid lowering therapy, but may not be optimized. And so I try and do the best I can to work with the patient's family physician or internal medicine doctor to optimize that. In general, in patients that have multiple vascular risk factors, we try and get that LDL down to at least 70 or below. And sometimes that's hard because of the adverse side effect profile of some of these medications. But absolutely is important. It's one of the big four when it comes to risk factors for PAD.
Marcia, go ahead and unmute. What is your question for Dr. Weichmann?
Now, if they have thrombus, for example, stent thrombosis.
She's having trouble unmuting.
Yeah,
There you
sorry. Go. Okay, got it. Yes. Again, thank you. Like Douglas said, thank you for joining us. We really do appreciate it. I was wondering about claudication, and I have full metal jacket, I think they call it, but I walk every day, and generally do very well. But some days it's a huge struggle, and other days it seems like I fly through it. Same course, maybe same treadmill, or possibly same trail, same time of day. And I'm wondering, is there a rhyme or reason as to why some days I don't struggle and other days it's a huge struggle?
That's a really good question, and one that we as physicians, when we hear a question like that in patients that have had a previous PAD treatment, in your situation, it sounds like you've had a couple stents placed, and a patient has continued leg pain associated with activity, or what we call intermittent claudication, exercise or activity-induced leg pain, which frequently, but not necessarily, can be from a vascular obstruction. So the first thing that I would wonder, knowing that you've had previous intervention, is number one, what studies have been done to exclude your persistent leg pain in terms of an ABI or a pre and post exercise ABI, because all leg pain is not necessarily vascular in nature. Sometimes what happens when we get focused in on a patient that has leg pain and we've treated them from a vascular standpoint, sometimes we take our eye off the fact that, patients do have arthritis. Patients do have sciatica. Patients do have neuropathy. So we sometimes have to take into account that, okay, we've treated a patient with vascular disease, successfully treated, but let's not eliminate the other things from our thought process. The other thing that I would just mention Go ahead. It looks like you wanted to add on to
I
something.
was gonna say, even though I've had all that, I am blocked again. I have restenosis. So I know, I mean, I shouldn't say I know because I'm not a scientist or, I don't have special powers, but well, I mean, we know I'm 100% occluded in my SFA.
Okay. Okay. So certainly we now know that that's certainly something that can contribute. And that's why follow-up is important. A lot of the things that we have for treating certain vessels are not 100% perfect. We don't have the magic bullet yet. That's why we keep doing the research to try and find out what's the right medicine, what's the right device, what's the right approach to risk factor modification. If we had a 100% magic bullet, then everybody would be getting that magic bullet and somebody would have won the Nobel Peace Prize for medicine. It's not me, it's not any of us so far to date. But the other thing I was going to mention is when leg pain is varied like that, you mentioned sometimes you do well, sometimes not so well. That makes it a little bit harder because the typical claudicant patient has this cycle of walking, pain, rest, and relief. Walking, pain, rest, and relief. And it's usually at very predictable distances, with the exception of maybe if you're walking up a hill, those symptoms may come on earlier. So even though we know you have vascular disease, you've had it treated, the stents or the interventions that you've had done before have not, things are occluded now. We still want to be mindful of the fact that, okay, there are patients that can have leg pain for another cause. And then it always comes down to whether or not your lifestyle is limited. We see patients frequently that have more mild symptoms, still have PAD, but they would have more mild symptoms from the standpoint that they may not necessarily be limited, or they may be limited for some other reason. They may have bad emphysema, for example, and they have to stop walking from here to there because they get short of breath rather than the leg pain. So that's why I mentioned before that it's important to ask the very specific questions that get to the heart of the matter, because it's one of those things that leg pain can be from another cause, and let's not lose focus on the fact that patients with PAD can have other causes of that leg pain too.
Marcia, is it the leg cramping that slows you down at a different time and place every single day? Or is it something else?
It's claudication. It's claudication. I mean, some days I can get out there and I just feel like, the world is mine. I got this. I can walk through. I mean, I always have pain, but I walk through it. And other days I just think, how am I going to get it done? This hurts bad. Can I get through it today?
Right.
Well, and that's a really good point to make. You mentioned that you kind of walk through the pain. That's, the old phrase, no pain, no gain. A lot of people get concerned when they have that pain and they feel like they're making things worse if they continue to walk. And really, that's not the case. We encourage people to walk to the point of pain, pause, walk again, pause, walk again. And the more you retrain those muscles to work on less oxygen and less blood, you're encouraging building those collateral vessels, which are critically important for patients that have either failed some type of intervention or maybe aren't candidates for intervention. So you're not going to hurt anything, and you certainly will be helping things by continuing to walk.
Sal wants to know when he should give in to having a fem-pop or fem-tip bypass versus having the doctor try an endovascular first approach. He says that his doctor doesn't even want to try endo, that says that it doesn't last. There's nothing durable about it. And the best option for him at age 65 is to have a fem-tip or fem-pop bypass. How does a patient know when they should try the endovascular first, or just go ahead and go with what the doctor says and do the bypass?
Well, first, Sal, I would say this. No device or procedure we have is 100% perfect, as I mentioned before. Angioplasty is not perfect. Atherectomy is not perfect. Stents are not perfect. Bypasses are not perfect. They all have some degree of limitation. And it's a very hard question to answer with regards to when is enough enough. There are patients where I have done numerous procedures on from an endovascular standpoint because they're not surgical candidates. There is data that supports good outcomes with surgical bypasses in certain situations. So we don't know the answer to when is enough. We can't say that you get 3 shots at it, or 2 shots at it, or 6 shots at it from an endovascular strategy standpoint. There's no magic number. We certainly don't have data that supports that if you've tried 3 times, 3 strikes, you're out. There's nothing that shows that. And anecdotally, there are a lot of us in this field that have tried numerous times to revascularize a patient to get them out of a limb-threatening or urgent situation. So there is no true number. Some of that is going to be based on physician bias. There are going to be surgeons that may have a shorter threshold to do a surgical bypass, whereas somebody like myself that does endovascular intervention may be more biased towards giving it another shot. The good thing is that we have a lot of tools in the toolbox to help improve the durability of our intervention. And if we can optimize medical therapy on top of that, then in general, patients will do well. But there are options, but we don't have an absolute cutoff.
Yeah, we always tell patients that it's really going to be a personal decision for you, but we always suggest to get multiple opinions from different practices because you have 3 different types of doctors that do treat PAD interventionally and surgically, including interventional radiologists such as yourself, interventional cardiologists, and vascular surgeons. And as you said, different doctors, different philosophies, different approaches, different thresholds, right, before going to surgical. And so it's really important just to explore all of those options and see what the doctors have to say and do what feels best for you. And then secondarily, the other one that we tell them to consider is, what are the contingency plans when it fails? Which one has more options for you once that procedure that you're deciding to have will fail, because they all will fail, but which one is going to give you more options and which one is going to give you fewer options when that actually fails? And so we always say it's really important to ask each one of those doctors, what's the contingency plan when this procedure fails?
Really good point, Kim. Again, it goes back to what I've said a couple times now, which is there's no magic bullet that we can apply to this situation. And there are 3 main specialties, all with our own inherent biases. The great thing is that there are options to consider. Some of that leads to a kind of I'll call it a lack of standardization of therapy, because we as physicians do have our own bias, and what works well in my hands may not work as well in somebody else's hands, and vice versa. So, and not everybody is a good candidate for an endovascular approach. Not everybody is a good candidate for a surgical approach. We're gathering data, we're learning a lot, and so I think that the field is exciting from that standpoint, but we don't have a standardization process at this point. So we can't really say that we've tried it twice, we've tried it 4 times, you got to do something different. I think there's a tendency to try and do something different depending on how durable your intervention might be. But the point is, an absolute number, we really don't have that.
And the other thing, we always suggest conservative therapy first. Make sure it's optimum medical therapy, prior to any procedure. Walking is medicine. But once you do have the procedure, one of my thoughts that I share with patients is that I always like endovascular first because it is minimally invasive and it gives you the opportunity and the doctor the opportunity to see how your body reacts once you do have the procedure. Are you the type of person that is going to have a very quick healing response? Are you going to clot really quickly? What's really happening? It also gives the doctor the opportunity in a minimally invasive way to go in there and even collect more data using an intravascular ultrasound or IVUS to better understand the morphology of the plaque and to better understand, the sizing of each one of your vessels. And so it's just a great opportunity to really collect more information, because when that fails, at least if you actually make sure your doctor always, saves a landing zone, protects a landing zone, and the landing zone being a place where that bypass could be reconnected and to reroute blood flow in your arteries. But make sure that the doctor does maintain that landing zone, but it gives them a chance to then say, you know what, endovascular failed. This is why it failed. Now let's go to bypass. And then you have that option, but at least they have a better understanding, right, of the morphology of the plaque and the vessels and how your body is actually, progressing with PAD. Because with a bypass, if you go straight to bypass, we've had so many go down, doctor, so many go down. And then the doctor says there's nothing we can do. And we're seeing more and more go down within months. And the doctor says nothing more.
Your point about maintaining a target for bypass is valid. There's a mantra among the endovascular community that we don't want to burn any surgical bridge. And I agree, most people in general would prefer an endovascular approach as long as they're a candidate for that approach. It's less invasive, the recovery is shorter. So for all those reasons, most people tend to choose a less invasive approach as long as you can get a decent result. The analogy is very similar to intervention on the heart when people undergo angioplasty and stenting in the coronary vessels for angina or acute coronary syndrome. Sometimes patients need to go to surgery, but sometimes patients, and frequently so, patients are treated effectively with a less invasive approach through percutaneous coronary intervention. The same applies for patients with PAD and critical limb ischemia. So, but again, this is a disease that we manage. We don't cure PAD. We don't have a pill that you take. And so when patients present to us with symptoms that are consistent with PAD, whether that's claudication, or unfortunately, sometimes patients present with the more advanced stage with CLI, we don't have the ability to cure that process, but we can manage things effectively through risk factor modification, smoking cessation, all that kind of stuff, revascularization procedures, to get you as functional as possible and ultimately to save limbs.
We have a question coming in from Pamela. Douglas, do you want to jump in first?
No, go ahead, Pamela.
Well, we have a question that's coming in from Pamela, and Pamela is asking, how do you know whether you should get a procedure in an office-based lab or in a hospital?
Well, that's a question that is somewhat loaded because there are plenty of facilities that offer angiography and intervention in a non-hospital site of service. Some of it is what is the access to that type of care in your community. There are roughly, and this is kind of a very rough estimate, roughly 800 office-based labs where these procedures are done. In the United States, these procedures are done also in ambulatory surgery centers, which is technically a different site of service, although it's still outside the hospital. Certainly, some of these procedures are done as an outpatient, but in a hospital facility. So the thing that I think is most important, and maybe this is what the question is really regarding, is it an option for me to have it one place or the other? And some of that is dependent on your treating physician. Are they operating from an OBL or an ASC, or do they only operate out of a hospital? We've seen data that has been published through the OEIS registry that shows that these procedures that we do in non-hospital sites of service are done just as safely as they are in the hospital. So that should be somewhat encouraging. In general, patients prefer to not be in a hospital. They would rather be in an off-campus, if you will, site of service. But it's very community dependent, and because sometimes patients will not be in a community that has a lot of non-hospital sites of service for these cases. But in Florida, we have a fair amount of them. In Texas, there are a fair amount of them. So it depends on where you live.
Okay, Douglas, go ahead.
I'm gonna piggyback on this. this also was mental health month for us as we talk about the mental health aspects of PAD. And so how do you work with your clients on that aspect with different doctors, all the things that we do go through? I'm having to change doctors again because I can't drive to where my doctor was anymore. I can't drive because I have an axial that is blocked and I just can't drive. So the mental health of going from one doctor, now I'm having to come back here and hoping I find a good doctor that is as good as the doctor I had up there. Make sense? So the mental health aspect of the back and forth, the up and down, I have my good days, I have my bad days. I have my days where I just want to give up, and my days I'm gung ho and let's get through this.
Sure. Well, I'll start by saying I'm not a mental health expert, but I can certainly understand from the aspect of good days and bad days that access to care and changing physicians is a real problem. All the more reason to have access to non-hospital sites of service that are a little bit more nimble and they can be planted maybe closer to you. It's a very complicated formula state by state to determine when and where a hospital can be planted. So, and it's not an easy task and it takes years to go through, whereas an office-based lab might be easier to plant if there's a need in the community. So certainly I sense your frustration with not being able to get to the doctor where you were before, and there's added implications with traveling to get to a physician that does the same kind of thing for you. But certainly from the mental health standpoint, we see a lot of that factor into the chronic patients that we take care of. There are patients that do have harder days, and with walking, for example, as we heard earlier, but transportation is part of it. Ease of access to the system is a kind of a deterrent to seeking future health care. And so patients kind of have this, patients can develop this somewhat depressed and kind of a nihilistic approach to seeking further care because it's hard to get from point A to point B for whatever reason. So those are all real issues and have tremendous impact with access to expert vascular care.
And we have a question coming in from Lisa, and it's about, what you experience after a procedure. And it's two parts, why a patient has significant bruising following an endovascular procedure, and also about the pain. What is normal pain following a procedure, especially an intervention? But she's also asking about surgical, if bypass or endarterectomy has the same type of pain following those procedures.
In general, recovery from an endovascular intervention is shorter than a surgical bypass, and it depends on the extent of surgery and the extent of the endovascular intervention. The bruising that you can see sometimes as a result of an angiogram or some type of endovascular intervention in the legs is most typically because of one of two things. One is we give a short-acting blood thinner during the procedure, and so that it usually has a very short duration, though. But a lot of these patients we will have on what we call antiplatelet therapy, or medicines like Plavix or clopidogrel or other similar type medications, and that thins the blood. And so when we're done with the procedure and we take that little tube or that sheath out of the artery, sometimes there is some bleeding under the skin. And as long as that doesn't become expanding over time, if the area remains soft afterwards, then that discoloration basically amounts to a bruise, and it usually goes away with time. In terms of the pain after an intervention, some of that also is dependent on the type of intervention that you had. If you're aggressively ballooning an artery, for example, in the superficial femoral artery, which is the main vessel in the thigh, if you have to really dilate that because it's heavily calcified and you dilate it aggressively with the balloon, some patients will feel that afterwards. And I usually tell people that usually lasts 24 to 48 hours. It gets better with a little bit of time. Some anti-inflammatories can sometimes be helpful, but in general, the recovery from an endovascular intervention is within a few days, whereas the surgical bypasses take a little bit longer to recover from.
Fantastic. And we have one from Marcia. Marcia wants to jump in again. And if anyone else has questions, go ahead and raise your hand. But Marcia had one more question. And it looks, there she is.
Hi. I was wondering, I've tolerated statins very well. Yeah, and I hear, so many people that have a lot of problems, but I'm pre-diabetic since starting them. And that's despite cleaning up my diet, since finding out I had PAD. And I was wondering, can statins raise your blood sugar?
Not directly. Not directly. There are certain medications that can sometimes raise your blood sugar. Some patients that are on steroid therapy, for example, if they have obstructive lung disease or if they're on chronic prednisone therapy for an inflammatory arthritis, sometimes that can wreak havoc with blood sugar. But in general, statins don't have a direct cause on blood sugar levels.
Thank you.
Fantastic. We just have a couple more questions here. Douglas, do you have another question? Is it short?
Yeah, quick. You had mentioned something about PAD and the nerve and how to tell as a patient, how do we tell the difference between like neuropathy or PAD?
That's a good question.
Really, really good question. And one that is difficult for physicians, for what it's worth.
Yes.
Yes. There are patients that definitely come in with the classic, what we call paresthesias, which is just a fancy medical term for numbness, tingling, hypersensitivity, where even just like the bed sheets touching your feet are intolerable. Those hyperesthesias or paresthesias are fairly typical of peripheral neuropathy. So numbness and tingling by itself isn't really the classic presentation of a patient with vascular disease. So if you have that, you have to think neurologic things in general. In other words, peripheral neuropathy, or is it somebody with a bad back, for example, that has referred pain from a pinched nerve or a sciatica type situation? But yeah, that's again, it goes back to the original point of not all leg pain is vascular, but not all leg pain is from your old football injury or from your sciatica or a bad back. We have to kind of keep all those things in mind when we're sorting those symptoms out.
I was just looking for you to wave your magic wand and tap all of us. And
yes, where did I leave that? I don't think I have it on me here. Where is my magic wand? They must have taken it.
You're awesome. I don't know. Some of the patients I've sent you all tell me you have magic hands. So you do perform some miracles out there, I believe. This is first what I've seen.
You're too kind.
So I think you do have a little magic wand in there somewhere. Maybe in the form of wires and catheters.
That's the best wand I can have, really.
Yeah, exactly. I just want to finish this off, opening up and letting Nancy, do you have a question? BK or Bobby, do you have a question that you want to jump in on? Okay, go ahead and unmute Bobby. Hi, Bobby. Me? Yes, we can.
I would just like to thank all of you from the bottom of my heart for being there today for me. This support group has given me a little new hope. And there's just one quick question I had for the doctor. I've seen 4 specialists. They did a bypass on me about 2.5 years ago, which failed. And the specialists that I've seen have all told me that they didn't want to touch it. Basically just wait until the pain gets so bad when I'm at rest, then to go to the emergency. And so I'm nervous about where I've been left with this disease. I was also told that if they try to go in and these were the best specialists in Orange County, California, that if they went in and tried to do another bypass, the collaterals that were at work would stop working and that I would be just better off going with the collaterals versus trying to get in there and do any more work on my leg. Anytime I put any pressure on it, I have a number 8 pain level. But my main objective is to keep my leg. So which way would you go on that, Doc?
Yeah, of course. And I think that's everybody's goal from the physician standpoint too, is to preserve limbs, because with preserved limbs, then we preserve lives. You're in an area of the country that has some outstanding vascular experts, no doubt. And again, bypasses aren't 100% perfect. You got a little bit of mileage out of it, sounds like, but they don't last forever. And we have had some success in doing endovascular procedures in patients that have had bypasses. A couple of patients come to mind off the top of my head of my own, where you can go back and do try an endovascular approach. Now, having said that, it's very anatomy dependent. So, in your situation, as I mentioned before, sometimes there are patients that are good endovascular candidates and not surgical, and vice versa. So it's a little bit hard to say without seeing what your blood vessels look like. But I certainly know of experts in your area that we can probably get you connected to for another opinion if that's something you're interested in.
Thank you.
So he has
Appreciate it.
not seen Dr. Mahmoud Razavi.
There you go. That's
Yeah.
a
I
good place
think
to
I knew
start.
you were thinking. Yeah.
Good
He'd
place to
be
start.
definitely a good place to start. He's also world renowned as well.
Yeah.
So we're going to get him hooked up with him.
Yeah, it's important to note that that may be your assessment of your situation, and the response from your vascular physician may indeed be the next person's opinion too, because there are things that sometimes we don't have a great solution for, but it doesn't mean that you shouldn't seek the expert of somebody like Dr. Razavi.
Thank you.
Dr. Weichmann, we really appreciate your time. Thank you so much for spending so much time with us this afternoon. Lisa did have a question. I see she just joined in. Lisa, did you want to ask a question of the doctor?
I wanted to ask, because I keep hearing about everybody having heart involvement and heart attacks and dying from strokes or heart attacks. And my heart, I just had my heart checked last year. It's completely clear. So is this still something that I need to worry about?
If you have PAD and you have had your heart checked out, that's good, because to your point, most people that have peripheral arterial disease don't die from that. They die because there is a correlation between the same underlying disease process in those patients with PAD and coronary artery disease. So if you have PAD, you certainly are at increased risk of developing heart attack or stroke from coronary artery disease or cerebrovascular disease. But you've done the right thing, or your physician has got you plugged in to do the right thing, which is, if you've got it there in your legs, we need to check your heart. We need to check your carotid arteries. So if it's clear, that's good.
And what test do
They're
you normally
clear.
suggest? That's good. What test do you normally suggest a patient discuss with their cardiologist for their heart? An echo, calcium score? What would make you feel comfortable that their coronary arteries are clear? Nuclear stress test?
Yeah, typically what we recommend is in my PAD patients is, if there's any clinical suspicion, we ask the usual symptoms: chest pain. Can you go up a flight of stairs without getting crippling chest pain, shortness of breath, all those things. In general, we like to start with physiologic tests like a stress test, especially if you've got your legs fixed and you're able to walk without symptoms. Great. If you can't walk because of some other reason, a bad knee, a recent surgery, there are stress tests where you can be given an IV medicine that simulates exercise. But the physiologic tests, like a stress test, are where we start. If those are suspicious, if they're abnormal, then typically we progress to imaging studies to confirm and look at the anatomy of the coronary arteries.
Great. Thank you so much, Dr. Weichmann. Really appreciate you. Appreciate your time. We hope that you'll come back on another. We have our What's Up Doc Tuesdays, and so would love to have you come back again later this summer to answer some more questions. We appreciate you.
Absolutely. Thank you very much for having me